To simulate a high peak pressure during inspiration, the instructor can select a high inspiratory resistance from the main panel, tap the airway resistance tile, and then increase both inspiratory resistance values and confirm by pressing the green button. You'll see straight away on the the student screen, the peak airway pressure has jumped up, almost encroaching the P max value, which is currently set at 30. If the instructor increases the airway resistance further, the student ventilator will react such that the maximum peak airway pressure now reaches the current setting of P max of 30, and therefore the breath is abandoned before the full tidal volume of 600 milliliters has been delivered. If the student chooses to increase the P max value, we'll confirm at 60, then the peak pressure is allowed to exceed the previous setting of 30, and this allows the full breath to be delivered that the student had previously selected. In this example, we can see that the plateau pressure is revealed because the 600 milliliter tidal volume has been delivered with a current flow rate of 60 before the end of the inspiratory time of 1.2 seconds. If we reduce the flow rate during inspiration, you can see the peak flow during inspiration is reduced, and it takes longer for the breath to be delivered, and therefore consequently there is no revelation of the plateau pressure. This should prompt the student to do an inspiratory pause maneuver if they wish to reveal the underlying plateau pressure by pressing the inspiratory pause button at the bottom of their screen. We can see now that the plateau pressure during the inspiratory pause was 10, and this allows the student to make decisions as to whether any high airway pressures were due to a resistance problem or a compliance problem. If the instructor wishes to simulate severe asthma and the challenges that presents with ventilation, they can make significant increases to the expiratory resistance, and this will have an appropriate effect on the flow curve. Here we can see that when high resistances are activated, the expiratory flow is very limited, and it takes much longer for the breath to be exhaled. If the instructor has made some inappropriate settings to the ventilator, such as an inappropriate tidal volume and an inappropriate respiratory rate and a long inspiratory time, we can see that there is an obvious failure of the expiratory flow to return to the baseline of 0, which then allows the student to realize that the breath has not been adequately exhaled and should prompt them to consider strategies to improve the ventilation of the asthmatic patient. The peak pressure is rising as the lungs become progressively hyperinflated, reaching their maximum capacity. And if we increase the tidal volume further to a very inappropriate level, then the peak pressure will rise further and further until it reaches the P max value. Obviously, the student would be expected to make appropriate changes to their ventilation strategy by reducing the tidal volume, reducing the respiratory rate, and reducing the proportion of time spent in inspiration. This gives sufficient time when all of these strategies are deployed to allow almost complete exhalation of the breath and a marked reduction in the peak airway pressure. Furthermore, as they administer or suggest administering bronchodilator therapy, the instructor can gradually reduce the airway resistance during exhalation, and this will have an appropriate clinical effect on the waveforms during exhalation. You can see that the maximum flow rate during the negative part of the flow curve is much higher, as there is less resistance to exhalation.